A very good evening to you and welcome to the Nation Leadership Forum. I'm Smriti Vidyarthi. Our topic of discussion tonight is universal health coverage. Are we on the right path to achieving it? What are the hurdles? And of course, what are some of the solutions? Well, joining me are a panel of experts, which include Professor Anyang' Nyong'o, the Governor of Kisumu County and a key player in initiating the process to provide Kenyans with universal health coverage. He joins us live from Kisumu County. Also on the panel is Dr. Mercy Mwangangi, the Chief Administrative Secretary in the Ministry of Health, Dr. Kanyenje Gakombe, the Chairman of the Kenya Healthcare Federation, Dr. Githinji Gitahi, the CEO of Amref Health Africa, and right here with me in the studio, Dr. Peter Kamunyo, the CEO of the National Hospital Insurance Fund, that is the NHIF. All my guests play a critical role in working towards achieving universal health coverage. Well, you too can join this conversation online on our social media platforms. Use the hashtag NMG Leadership Forum, and you can also tweet me at Smriti Vidyarthi or at NTV Kenya, and we'll try have some of your questions answered. All right, so I'll kick off with you, Dr. Mwangangi, and you have been among the team that initiated the implementation of UHC. You have a vast background on its birth as well. What is the principle behind universal health coverage? And I'd like you to go to specifics. So, for example, if I'm a woman in Meru who's been diagnosed with cancer, for example, what are my rights? What does UHC mean for me?
Thank you, Smriti, and thank you for the opportunity to be able to discuss UHC, which is one of the big four presidential agendas, and to my panelists who are key collaborators and partners as we try to move towards UHC in Kenya. Technically, if we look at UHC, the whole idea of UHC is ensuring that Kenyans are able to get services, and that these services are services that are responsive to their needs. So, for example, like you said, if you're a woman who has cancer, you're able to get good cancer services. The services are available to you, they're close to you, and that when you access those services, they're of good quality, and that then, therefore, good outcomes, and therefore also they do not dig deep into your pocket and hurt your pocket. In other words, there should be a mechanism or a framework to ensure that you do not undergo financial burdens as you seek that healthcare. So those are the key three principles: that the care is good, it's near you, it's essential, it's of good quality, and that it reduces any financial hardships as you access it. So any mirror that you're looking at, for example, cancer care, if you're looking at TB care, HIV care, if you're looking at COVID-19, you're asking yourself, if Kenya is on this journey towards UHC, then this care needs to be more accessible to Kenyans. It needs to be care that is of good quality, and it needs to be care that is affordable to the pocket.
All right, thanks very much, because certainly we do know that health is expensive, health care is expensive here in Kenya. Now, before I come to you, Governor Anyang' Nyong'o, I'll turn my attention to the NHIF CEO, that is Dr. Peter Kamunyo, because the NHIF is one of the driving forces as well behind achieving UHC. And in order to achieve it, there are some amendments that have been made by the NHIF. One of them is the NHIF Amendment Act, and this act requires compulsory contribution towards NHIF by even the poorest of people. What is the rationale behind this act? How is it going to help us achieve UHC?
Thank you, Smriti, for also inviting me to the Nation Leadership Forum. And as you've just said, healthcare costs. And because of those costs, every year, 1 million Kenyans are driven into poverty due to high healthcare costs. And to be able to contain this, to be able to get to UHC, whereby everybody has access to the quality care that they need without that financial hardship, without getting into poverty, we need to have mechanisms to be able to support them. And one of them is risk transfer. Now, in risk transfer, it means like the model that we're adopting now, which is what we call an output-based model, is where you pay a premium and then you get a whole host of benefits. Now, what has been happening traditionally from the time NHIF was formed as a department in Ministry of Health and continued in 1972 invited voluntary membership, whereby any citizen could contribute and get those benefits. What we have noticed progressively is that the voluntary members are not consistent in their contributions. So you find that like currently out of the 10.1 million households that are members, only half, about 5 million, are active. Meaning that the other who had joined before, even if they required, like that lady in Meru, if she had not been paying her premiums, should not be able to access those benefits. Yet the premium is so small at 500 shillings per month. So the other challenge that we've been having with that is that a lot of the members then join only when they have that need and then exit or default after they've already gotten that need. Or in some instances, try to join quickly while they're still on the hospital bed. Now, this creates a challenge in terms of them having that access to that care at the time of need. And also creates a strain on the fund because it is adverse selection, because we're only having the members who are who are requiring the need, requiring to go to hospital at any point. So obligating every Kenyan is part of the ways to ensure that all Kenyans have that access.
But Dr. Kamunya, you say 500 shillings a month. There are millions of Kenyans out there who simply cannot afford that much money. So how then are we going to sort of ensure that they pay that when really they can't afford it, and it's just going to drill holes deeper into their pockets? Let me bring in Professor Anyang' Nyong'o here to respond to this. Professor, in light of this, are we really applying the principle correctly in your view?
Thank you so much. Well, I share a lot of things that Peter Kamunya has said, but let us begin from the principle of universal health coverage. Our constitution says that every Kenyan, without any exception, has access to quality and affordable health care, including reproductive health. That's the principle in our constitution to which we all as citizens and government are committed to. The next question we ask ourselves, to what extent is the Kenyan nation and the Kenyan people capable of affording access to this quality health care? And that will depend on the wealth of the nation as well as the wealth of individuals. Now, you are right, there are certain individuals in the nation of Kenya who don't have the income that can make it possible for them to pay 500 shillings a month as members of NHIF. That means, therefore, that they don't have the wealth that it requires to pay that money. These people are usually called indigents. It is then the purpose of government, both the county and national level, to find ways and means of making sure that these people have access to quality and affordable health care, which means that you have to pay for them. In Kisumu County, for example, we have established the Marwa healthcare scheme, whereby about 45,000 indigent families are paid for, and one family may have an average of 3 to 5 members. What we are doing is that the county government votes every year 147 million shillings. Farm Access gives us a contributory fund equal to that, and this is an experiment we are carrying out to make sure that everybody contributes to the kitty that supports universal health care. Now, of course, there may be many models that can be used to support the indigents, and that depends on the national conversation that we are now having. And finally, it is important to understand that the way that we should contribute to universal health care should not be based on each one of us contributing the same amount of money. There's a principle we need to use to implement Article 43 of the Constitution. That is, from every person according to his or her ability, to each person according to his or her need. That means that, for example, I'm a governor. I should not be contributing to USC the same amount of money that my driver contributes, because my ability to pay is higher than my driver. So I will contribute to the kitty much more money than somebody who has less. In other words, contribution to the kitty that supports universal health care will be based on a graduated contribution in terms of income or ability. Once that is accepted in law, then it's very, very easy to cover the indigents, because we are not going to fall sick at the same time, nor are we going to need information or education or preventive health care at the same time. Finally, I want to say this. We should not call National Health Insurance Fund a National Hospital Insurance Fund. That's a very morbid way of looking at health. Health should be primary health care, preventive health care, educational health care, so that when you have proper preventive health care, you will pay less for curative health care, because people will be much more aware to eat proper food, perhaps to exercise, to prevent getting diseases by having access to clean water and so on. So I really think that it's high time we change the name of the National Hospital Insurance Fund to National Health Insurance Fund.
All right. All right, thanks ever so much for that. Dr. Gakombe, I'll bring you in now. We've been discussing the Amendment Act and various views coming out on what that Amendment Act intends to achieve. But in your view, what are some of the consequences if this bill does go through?
Thank you, Smithy. I hope you can hear me.
Yes.
I didn't hear much of Professor's contribution. The fact of the matter is that people don't like paying for insurance, so it is important that there is a mandate. But that then brings in a big challenge, which you've raised, which is how do you distinguish those who cannot afford to pay so that somebody else pays for them? Because in the absence of that, then the poor will not be able to get cover. So that challenge, especially in a country where the majority are in the informal sector, is a challenge that has to be overcome. And what we've got to be able to distinguish is the difference between the poor and in the informal sector. Because those who have income but are in the informal sector should pay by mandate, the same way those who are in employment now pay by mandate. So that's a fundamental principle. The second fundamental principle is that as we devolve healthcare the way we've done, counties get a budget. So it is important that we remember that the only money to fund healthcare is not through NHIF. There is tax money that is either comes through the central government or comes through the counties, and it's significant. And we must put that money to good use so that it can help the poor to access healthcare. The other fundamental principle is that right now, each county gets funding based on the people who live in the county. And if Kisumu, for example, is providing better care than Busia, then people will cross over from Busia, where their funding went to go and consume money meant for Kisumu County residents. And we therefore have to separate payment and provision, because otherwise it makes sense for a governor not to invest in healthcare and let the people cross over to the next county and spend somebody else's money. So the fact that we devolved means we also have to make sure that payment and provision have to be separated. So implementing the mandate is the key to ensuring that everybody is paying before they are sick, so that when you're sick, you can access healthcare. Coupled with that is the fact that right now, apart from NHIF, there are several other sources of money. One is employers. Many employers actually provide health benefits, and they pay the money either directly to providers or they pay the money through third parties who they give to administer, or they actually buy insurance.
Right.
The moment employers are asked to pay alongside their employees, there is a risk that they stop paying for private insurance So the money that goes to private insurance will no longer be available to provide health care or to pay for health care for Kenyans. So we have to make sure that the system we design builds all the pillars. NHIF becomes a larger and stronger pillar, but not at the expense of the other sources of funding, which is employer pools.
Right, Dr. Gakombe, I'll just interject there. I've got to bring Dr. Githinji in at this point. Dr. Githinji, many suggestions put forward there. In your view, how can we support these NHIF reforms?
Well, I think, Smriti, thank you very much. And, I'm listening keenly to the contributions of the others. And the one thing we need to understand, because we are talking to the general public, is what are we talking about? How much money are we talking about? Yeah. I think it's good for people to know that generally in Kenya, each person spends about 8,000 shillings on health per year. That is when you take the total amount spent. That is spent by the national government, county government, individuals from their pockets, everything together. Comes to about 8,000 shillings per person. When you multiply that by 50 million, then you can see we spend about 400 billion Kenya shillings. But where does this money come from? Because this then helps us to understand this thing that we're trying to explain here. This 400 billion, out of that, the individuals contribute about 20 or 2,000 shillings per person per year on average. This is an average figure. Then the government contributes about 3,500 to 4,000 per person per year through the national government budget and through the county government budget. And the balance of about 20 comes from donors. Donors contribute about 100 billion in a year. So when you look at this, you're saying the 80. So what we are discussing right now is if the government is putting in 4,000 shillings per person per year through the national government and county governments, yet we need 8,000 per person per year as we are currently spending, it means that we have a gap of about 200 billion, and this is coming from people's pockets. And this is where the challenge is, that if this money is coming from people's pockets and donors, then it means that people are then going poor, as Dr. Kamunyo said, about 1 million every year. The question is, this money that people are getting out of their pocket, we know now people are paying money in hospitals. How does that money get pulled together into a social health insurance scheme? And that is the National Health Insurance Fund. I support Governor Nyong'o that should be health insurance, not hospital insurance. Therefore, the question here is, there are people who are spending part of that money that people are spending out of pocket, but because they can't afford it, they're selling their cows, they're selling their land, but they have to spend because health cannot wait. So those people should be excluded from contributing, and they should be covered by the taxes that we pay, and should also be subsidized by those who are employed and are contributing, which is why the proposal to actually have employers also top up employee contributions is critical, because it allows the cross-subsidization. This is what we are talking about, and therefore the reforms in NHIF are leading us to a point where we have enough money to cover the 400 billion that we need, but also protect the poor by ensuring that the government provides money to pay their premiums. And then the missing middle, those who are actually in the informal sector, they are not poor, but they're not formally employed, are the people who should be mandated through their business renewal, through their PIN numbers, through their license numbers for their vehicles, to ensure they are tied to an NHIF payment, premium payment. That's the mandatory part, to bring in that missing middle. And then we will have sorted out the formula for the 400 billion that we need, at least to provide some basic primary health care in this country.
All right, Dr. Githinji, thanks very much. Dr. Kamunyo, I'll give you the right to reply to all of those comments, but I'm afraid we've got to take a quick commercial break first. So do stay with us. You're watching the Nation Leadership Forum. The conversation continues after this break.
Today tastes like a piece of the action, and it never tasted this good.
I have to admit, I didn't like Sukuma Wiki when I was growing up, but now I've created a way to make Sukuma Wiki tastier and meatier. I simply add 2 Royco beef cubes, and the end result is a rich, meaty flavor. And today, I have brought along my harshest food critics for a taste test. My kids.
More, please!
Royco beef cubes. Add 2 small cubes for a big, meaty taste.
For an exclusive fragrance experience, try Nivea Men Deep Impact Body Lotion with a long-lasting woody fragrance, deep moisture, and a fresh skin feel. Make an impact with Nivea Men Deep Impact. Nivea Men, it starts with you.
The UHC journey is on. To ensure no one is left behind, the Kenyan government launched EduAfya 3 years ago. EduAfya Comprehensive Medical Scheme covers all public secondary school students on outpatient and inpatient services, dental and optical cover, group personal accident, group life, last expense, emergency air and road rescue, and overseas treatment. Through EduAfya, the program has supported close to 3 million students to access affordable healthcare, thus fulfilling universal health coverage. For generations, NHIF has been the one insurance provider that has consistently turned up for Kenyans from all walks of life, without too many conditions, making sure you walk every step of life with confidence.
What would you do with 50 million
Kenya shillings? Kuna vitu mingi. Mimi nataka nyumba, nataka gari, all that can accommodate. Nataka ku travel, I need new things.
Lotto is now bigger and better kwa sababu you can now win yourself big amounts of money in the daily draw, the mega jackpot, and of course 100,000 Kenya shillings each and every day of the week minus Wednesday and Saturday.
Tunasema kuwa utanuke na Lotto. What that means is right now ukiweka ile stake yako ya 50 shillings all the way to 1,000 Kenya shillings, we multiply that by 50,000. Kama umematch all your 6 numbers. That means ukicheza for example na 1,000 shillings unaweza kuwa multimillionaire. You can win yourself 50 million Kenya shillings, our new jackpot amount.
Swali leo ni wewe utazifanya nini na 50 million Kenya shillings? Paybill number kumbuka ni 7770000. Account number ni live. Kila laheri, changamka, cheza Lotto.
Hi there, welcome back. You are watching the Nation Leadership Forum, coming to you live from the Nation Center. My guests still remain. They are all experts when it comes to matters universal health coverage, and that is what we are discussing tonight. You can contribute to the conversation too. Just head on to social media and use the hashtag NMG Leadership Forum. You can also tweet me at Smriti Vidyarthi or at NTV Kenya. All right, let's pick up the conversation. Professor Anyang' Nyong'o, you wanted to contribute and comment on something that Dr. Githinji said before we took that break. So go ahead.
Yeah, Dr. Githinji said something very important. In actual fact, he gave us figures on what it costs to run universal healthcare in Kenya, or NHIF for that matter. Now, let us agree on one thing, that you can't have a health system without having a cost to it.
Yeah.
Secondly, that cost must come from somewhere. The money must come from somebody. Thirdly, we have people in our nation who are not capable of contributing to that kitty. These are facts. These are facts in our nation that we should confront. Now, when we got independence, the KANU government then brought the policy of African socialism and its application to planning in Kenya. And there was one principle in that document called mutual social responsibility. In other words, all of us as Kenyans should take responsibility for each other's present and future. And that is those who do not have much to support themselves should have a social system whereby they contribute what they can, and then the rest is met by the rest of society. That's the principle behind universal healthcare. Secondly, it has been said that Kenyans default from paying. Now, we know that health is now a devolved function. Counties and national government look after health in terms of cost and service delivery. Now we know from a county's experience, my county's experience, for example, that one of the ways by which you can reduce defaulting for paying NHIF is to use communities. For example, we have community health workers. They do very well in involving communities in primary health care. They could do very well also in making sure that in communities, people contribute to NHIF under the principle that I stated earlier, from each according to his or her ability, to each according to his need. We have left out community involvement in making sure that universal health care works. This is now the time that we should now get NHIF devolve itself to the counties in terms of making sure that contribution to NHIF under a principle that should include those who do not have the means to contribute is taken care of. In our county, we have this method of Marwa social health care, which actually is working very well and could easily be replicated nationally. And very finally, workers and their employers should be engaged in contributing to universal health care. If National Social Security Fund can't be contributed to by employers, I don't understand why employer-employee co-contribution to an NHIF cannot work.
Okay. All right, thanks so much for that. And now let me put all of those comments to you, Dr. Kamunyo. So much advice coming your way. What is your response to some of those issues that have been brought up?
Thank you, Smriti. Great conversation there. And I'm glad that there's one agreement that all who can pay should pay, and those who cannot pay to be identified and supported. And the reason for this is to create enough funding to create a sustainable model to be able to drive us towards UHC. And indeed, towards this, the initial steps have already been taken. Based on the last census of 2019, we know that there are about 5.1 million poor households or indigent households. And through the Ministry of Health and in collaboration with the Social Department of Social Protection and together with the county government, we've developed a tool to be able to identify the indigents all the way down to the counties. And the government has taken the first step in supporting 20% in phase 1 of these poor or indigent households. About 1 million households have been identified. We've already registered them into NHIF system and waiting for funding for them to be able to join and have what 20% covered. In addition to that, as Professor Nyong'o says, many counties have also taken the initiative and like through in Kisumu County through the Marwa cover, which is supported by NHIF, they've been able to identify and support already 45,000 indigent families. And in waiting for another 45,000. And there are many other counties that have taken that initiative. Counties like Lamu, who are supporting about 20,000, and many others, including at constituency level, where several members of parliament using their CDF funds to support the indigents. So this is the way we will be able to achieve UHC. But ensuring that those who can pay, do pay, those who cannot pay, to be identified and supported. And as we go towards ensuring also the employers put their skin in the game, it would be good to note that, and I like that Dr. Gitahi is bringing figures. I do love figures as well. The employee contributions actually start from 150 shillings to 1,700, where it is capped for individuals who earn 100,000. And I agree with Professor Nyong'o that it should be equitable payment depending on your income. But what does this mean? It actually means that about 13% of employed folk actually pay less than the mama mboga who does not know whether they're going to make a shilling or not during the day, and the other self-employed or informal sector. So, and 61% actually pay less than 1,000 shillings. So that means that there is indeed here also a gap in an environment whereby we have also guaranteed incomes. And let us also note that it will not stop employers from buying private insurance. In this country of ours, the insured individual, privately insured individuals are about 2 million, meaning it's about 500,000 households. And they account for, or they contribute about 44 billion shillings to the private insurance industry. Put that into perspective with NHIF, whereby we are gearing to cover 98%, the remaining 98% of the country, and currently the membership that we have, about 10.1 million principal members and about 13 million dependents, and collecting from them only 38 billion for all that myriad of benefits. So in this scenario, and if we borrow also from other countries that have been able to achieve UHC, and I'll pick a country that is one of our neighbors, Rwanda, for example, there's a myriad of taxes, including 0.5% of their gross salaries from the employer, in order to be able to build this pool.
Okay.
And as Dr. Githinji has said about the total figure, and that is to run the entire healthcare system. Professor Nyong'o said that there are different inputs. What we are looking at to be able to provide through NHIF is a risk transfer, that at the point that you get sick, you're able to get to a hospital, like that lady in Meru who has cancer is able to have the diagnosis done, is able to have surgery done, is able to get their chemo and walk back home without paying a single shilling from pocket.
All right. Thanks so much for that. Now, in addition to being able to finance this, human resources are required. We need doctors, we need nurses, we need the healthcare workers. We also need the infrastructure. We need the hospitals and the clinics as well. But we do face a shortage. Dr. Mwangangi, these issues are some that hinder our path to achieving universal healthcare. So how can we address this?
Thank you, Smithy. Professor Nyang said an important point, and this was emphasized by Dr. Githinji, that NHIF is a vehicle and a very useful key vehicle when it comes to achieving UHC. But we have to remember that investments have to be made in other key pillars in health. And you're very right, human resources is perhaps one of the key engine drivers of achieving UHC. And what we've done as government over time is that we've actually increased the number of healthcare workers. And particularly, one of the big fruits of devolution has been an increase in the employment of all cadres, from doctors to nurses to physiotherapists, all the 16, 17 cadres that exist in the health sector. We've seen an increase in that number. And I think most recently, about 2-3 years ago, and even last year, as we started to deal with the COVID-19 pandemic, we were able to employ more human resources, particularly giving an opportunity to the youth to participate in the health sector. And so we had an internship program running, about 2,000 young people who are employed under the UHC program to serve in different parts of the country. What we do see is that we do have to start thinking about new ways of ensuring that there's efficiency when it comes to human resources for health. There is no country in this world that has been able to achieve the set number of healthcare workers it requires per population. And therefore, what we need to do is to be innovative and ask ourselves, the doctors that we have, the nurses that we have, the physiotherapists that we have, how can we ensure and support them to be more productive and to be more efficient? How do we look at different mechanisms of contracting to ensure that we're actually having those hours at work being utilized, as opposed to having individuals serving in different positions, but perhaps not as productive? And this is one of the key things that's being spearheaded in the Ministry of Health, but also in collaboration with Public Service Commission and the Ministry of Public Services, to be able to really look at the wage bill in this country comprehensively and agree how do we ensure that we actually have the right labor force that's required, that has the right skills, but also that is able to give us the productivity that we need. I think a key component that has been mentioned today is also the investment in community health workers. And perhaps what we would call this is having that link of the community with the health system, investing in having that community health worker available and present, but also having more participation by the Kenyan when it comes to their health. I think you've seen the clarion call for COVID-19 has been about individual responsibility. And I can tell you the individual, the person, is the center of this UHC journey. And so there's also that element of being responsible, seeking healthcare, ensuring that you have good health-seeking behavior, you're going in for your preventative checks, and you're participating in the health system, as well as in policy design and implementation. I think another key thing that we've noticed is that Kenya right now, particularly when you look at the health facility density, we've more or less reached the target that we had. We've been able, through devolution for the past 9 years now, invested a lot in brick and mortar. We have facilities spread across the country. And right now, the next step, with the next 10 years of devolution, should be a focus on ensuring that the current infrastructure is functional and that we don't have white elephants across the country, and that these facilities actually have the needed health workers and the needed commodities and medicines that are required. And speaking of medicines and commodities, it's important to discuss this today as we discuss UHC. Dr. Kamunyo mentioned out-of-pocket expenditures. The whole idea of all the policy interventions that we have in place are to reduce the cost that the Mwananchi is spending when it comes to healthcare services. And all the studies we've done have shown us that the biggest cost driver is actually the medicines and the commodities, the drugs. And we've done a lot of assessments and found, huge disparities in the cost of medication. There are some medicines that are very expensive here in Kenya, compared even to the UK, compared even to America. And so what we're doing in the Ministry of Health is that we already have a task force. It's called a price regulation task force. And it's working to look to see how do we partner with all the players in the health sector to ensure that we actually reduce the cost of medicines and drugs. And so this is something that has to be part and parcel of the UHC journey for Kenya.
Right, thanks. So you talk about collaboration, and of course, this also requires multi-sectoral collaboration as well as individual responsibility, and as well as the government playing its role. Dr. Gakombe, what role do you see the private sector playing in achieving universal health coverage?
Simiti, before I even address that point, I think there's a point we can't emphasize enough, which is that the cheapest healthcare is the healthcare you don't need.
Right.
And we therefore must do everything we have to do to prevent people from falling sick. As has been apparent during the COVID pandemic, no healthcare system is big enough to handle a large population, a large part of the population when they fall ill. So we have to do prevention, because the next cheapest point is healthcare at a dispensary. So that is absolutely fundamental. Now, coming to the question of what can the private sector do, or what does the private sector do? The private sector is involved across the entire value chain in healthcare provision. It makes the medicines, and therefore the cost of inputs and medicines is something driven by the private sector. At the other extreme, we provide healthcare. And without, if you look at Kenya's healthcare provision matrix, there is government, faith-based, and private. And if you remove the other two pillars and leave only the government, then we have a major problem in terms of access. Even if people had insurance, they wouldn't have access. So the private sector basically works alongside government in every aspect of healthcare delivery. We are even involved in as stakeholders in regulation. So even this UHC journey, we have to work together so that every part works better than it does. And of course, we provide the technology that will be needed to connect providers with payers. Because the moment you have a system where people pay before they get service, then you have to have a system for collecting the revenue. And the private sector basically provides the infrastructure and the technology. You have the systems to pay providers, and the private sector will do that too. And indeed, the biometric system that NHIF launched is private sector provided, and there are other players in the country who provide those kinds of systems. Within hospitals themselves and healthcare facilities, in the absence of systems, data collection, data analysis to detect fraud, to compare outcomes, to match peers, to see who is delivering better quality healthcare than another one, the system will not work well. So the private sector is, in a sense, the glue that ties all the pieces together to make sure that the system works effectively and efficiently.
Okay, thank you. I want to bring up the topic of gender inequality that also influences access to healthcare. Dr. Githinji, I'll bring you in for this question. How is it that we can ensure that women and girls as well get catered to under the universal healthcare umbrella, universal health coverage umbrella?
Thank you, Smriti. This question has kind of multiple dimensions. I think the first dimension is that we know that women and girls are generally disadvantaged, and they're disadvantaged because of many factors. One factor, of course, being that the development of education and equitable education for girls is affected by teenage pregnancy, and therefore they result in dropping out of school. Therefore, it affects their overall future economic activity. So generally, women are left behind, and many people don't understand why we advocate for women and girls. It is because of this issue of the increasing gender gap that is not there up to about 10 years, but starts between 10 years to 20 years of their age because of teenage pregnancy, dropping out, and the men continue to study. So there is first an economic vulnerability, which means that as we look at the model that we've discussed here of supporting vulnerable households, including the indigent, majority of them will be probably women-led, and those must be considered. So we must not be gender blind as we do the identification of indigent households that need to be supported. We must wear the gender lens. The second thing is that we must also decide what services, as we do the package of services, because again, if you go back to this conversation, we talked about 400 billion. The question is, what is it buying? And that is the answer to this question. That as we consider what the 400 billion is buying, we must then package what is NHIF. Even if we got 200 billion and give it to NHIF, what are they going to buy with it? And that's the question of strategic purchasing, that you're buying for a country what a country needs. If you look at packages of support, the question I would ask NHIF is, does NHIF cover family planning, for example? Does it cover family planning commodities for adolescent girls that need to access family planning, or even for young girls who need to access family planning to ensure that they can make decisions about their sexuality and they can continue with schooling so that we reduce the gender gap? So in designing the package that we are purchasing at county level, at national level, through NHIF, we must then wear the gender lens. And I'm very grateful that the government of Kenya has put in what we call the Linda Mama program, which then ensures that women who are pregnant can access the right services. That part of UHC, Linda Mama, is actually a UHC program. The question that I want to finish with, the answer I want to finish with here, Smriti, is eventually, then we must also orient the service delivery to serve the women and girls. That if you are providing the services, they must also be accessible. One of the challenges I have seen when I visit health centers with Linda Mama is that women go there when they're pregnant. The payment for delivery is free, especially in public. It's free. But then there are no commodities. There are no reagents to do the antenatal profile. They are told to come with gloves. Why so? Yet the money is available. It is because of a big issue of denying facilities, public health facilities, denying them financial autonomy to be responsive to the services they need to offer to those women and children at a local level. I want to mention here that out of the 50 million billion that NHIF pays out, only 30% of that, about 15 billion, goes to public health facilities. The other 35 goes to private. Why so? Because the facilities in public are not capacitated, they are not given autonomy to actually retain the money they provide services for, and therefore they don't even claim for NHIF. We must resolve this issue if we have to be responsive at a local facility level to the woman, girl, and child who is going to seek services.
All right. Thank you, Dr. Githinji, for giving us insight on what's happening on that front. We'll continue this conversation again. We've got to take another quick break on the Nation Leadership Forum. We are discussing universal health coverage. I do see a number of you have sent in your comments and your questions. I'll try get to them shortly, but first let's take a quick break. Stay with us.
When they flip and roll and start to crawl away, tape diapers can be hard to put on. Then it's time for all-round fit Pampers pants. Easy to pull on even when they're moving around for a great fit and up to 12 hours of dryness. And easy to remove. Just tear the sides, lift away, roll up the pants, and you're all done.
A 2-piece pack now available at only 50 bob.
Get fresh, gotta get fresh.
Downy's a boom boom pow, Downy boom boom pow. Smells bayana uchafuzi na zibita improve Downy. Protect nguo zangu na nukia niko safi. Lazima niwe fresh na Downy's boom boom pow. Boom boom pow, Downy's new boom boom pow. Smells zote na zi boom boom pow, powerful freshness. Downy's boom boom pow. Nani 15 bob too?
Wonderful, your baby's quite active. After I discovered Molfix, I rediscovered my baby. She's jumping and running around. Well, we call that the Molfix Comfort.
Thanks to its elastic side bands, Molfix provides freedom of movement for your baby.
All babies deserve a high-quality diaper. You should also try Molfix.
I have to admit, I didn't like Sukuma Wiki when I was growing up, but now I've created a way to make Sukuma Wiki tastier and meatier. I simply add 2 Royco beef cubes and the end result is a rich, meaty flavor. And today, I have brought along my harshest food critics for a taste test. My kids.
More, please!
Royco beef cubes. Add 2 small cubes for a big, meaty taste.
Geisha coconut milk and honey, enriched with coconut milk for soft and moisturized skin.
Be strong and last long.
This is NTV.
NTV News Headlines in association with ABSA.
Tonight, holding on for silver for second, Kenya's Teresia Gateri and Zina Yego in a 1-2 finish in the women's 3,000 meters race.
Knows that work is going to come strongly. Trying it.
Benson Kiplangat bagged Kenya's first gold in the championships. Medals made in Kenya at the World Under-20 Championships. Also tonight, chaos and uproar after another curfew killing in Kayole.
Jana usiku masaa ya curfew saa 4 askari waliua mtu wa bodaboda.
Hatuwezi uliwa na corona na tuuliwe na mapolisi wenye wanafaa tulinde.
Police stand accused and IPOA opens probe on the Kianjo Koma brothers killings. More evidence implicating the police in an alleged cover-up plan. And
lakini nimesema hata kama nimevunja sheria mpaka nisalimu watu.
Raila Odinga remains consistent in law-breaking. Deputy President William Ruto also acts as one above the law. Wananchi killed for flouting the rules, but the big boys freely flout and campaign. Plus,
you must embrace forgiveness and not vindictiveness.
Nyanza region leaders endorse Raila Odinga for president.
We are talking about Raila Odinga. We are talking about a product that is sellable and marketable very easily.
Oko principals deny being forced to back Odinga at Mombasa meeting.
No one asked or even suggested that we support anyone for anything.
NTV News Headlines in association with ABSA.
Manage your card from your phone 24/7. Freeze and unfreeze lost or stolen cards. Manage your limit and change your PIN on the ABSA mobile banking app. Another digital innovation that gets things done. That's Africanacity. That's ABSA.
Hey, now that's hitting the right notes. When life gets boring, we bring out our play. You see, playfulness is in our DNA. It's in the way we move and laugh. It's in the way we walk, the way we rock, and how we just don't stop. You feel me? We add color to everything, to every day and every dish, because the world needs our crazy. We're the different flavors that make life more exciting. We're the ones who add color to every moment. Fanta, color every moment.
Manage your card from your phone 24/7. Freeze and unfreeze lost or stolen cards. Manage your limit and change your PIN on the ABSA mobile banking app. Another digital innovation that gets things done. That's Africanacity. That's ABSA.
Selena! Don't get puzzled. She's my twin. I shine your toilet. And I bathroom. So, is your bathroom clean?
Yes!
Presenting the new Harpic Bathroom Cleaner. Compared to ordinary detergents, its thick formulation gives you superior cleaning and kills 99.9% of germs and viruses all around the bathroom. Blue
For the toilet.
and red
For the bathroom.
Harpic Bathroom and Toilet Cleaner cleans and kills 99.9% of germs and viruses.
Robisearch Limited Point of Sale Software or ERP will help you monitor and control your stock, services, cash flow, sales, invoices, expenses, profit, suppliers and customers remotely with no stress. Robisearch Limited offers the best point of sale system that can manage your stock, sales, various reports, invoices, accounting, accommodation, payroll, production, serial number and Lipa na M-Pesa real-time module. Grab the offer now.
Today tastes like a piece of the action, and it never tasted this good.
Hi there, thanks very much for staying with us on NTV. You're watching the Nation Leadership Forum, coming to you live from the Nation Centre here in the capital. And the topic of conversation tonight, achieving universal health coverage for all. Thanks very much to all of you that have written in via Twitter. I'll just read some of your comments, and we have, let's have a look here. Daughter of Africa, you say Kenyans are struggling with daily food. The idea of health insurance is therefore not a priority. Let taxes offer Kenyans free primary health care. So those are your thoughts. We have another one. Ricky, you say we need to impact goodwill to Kenyans by assuring them that this is a needful, viable project. Transparency in dispensing information to Kenyans is also key. And then we have some other points here. Let me just have a look. All right, we must shift the conversation, George Kimathi, or you say, of UHC from just covering hospital costs to promoting health and wellness, promotive and preventative health as well. Access to services, not just care, adopt a holistic primary healthcare approach. So do keep your comments coming in. And my guests still remain with me, Dr. Peter Kamunyo, NHIF CEO. We are still amidst the coronavirus pandemic, and people's bills are going through the roof. In fact, there have been a number of unreported deaths, we believe, taking place at home simply because people cannot afford to take their family members to hospital to get treatment for the COVID-19 pandemic, or the virus, I should say. NHIF isn't paying for COVID. How then are we going to succeed in paying for all other illnesses under UHC?
Thank you, Smriti. And indeed, NHIF does not discriminate against any illness, does not discriminate against age, does not discriminate against gender. and does not discriminate against pre-existing illnesses. And this has been the principle of NHIF. And even when we look back to even previous pandemics, for example, and I'll pick on like HIV. When HIV came and we were all naive to it, it was an exclusion in almost all insurance companies. But after developing treatments, understanding the disease, we're able to cover it. And now it is covered fully. Now, in the case of the new pandemic, now COVID, and you mentioned that initially because this is a condition that we now do not know the extent, we do not know how long it will run, we do not know how much it will cost. So the current models are not there to be able to support that. And it's good to understand that even as NHIF, being an insurance model, we collect a premium for a certain set of benefits. And it is for the reason of this to be able to have a holistic cover, that the proposal that everyone contributes so that we can be able to pool enough resources to be able to cover all illnesses, whether it is a pandemic or what, in terms of enabling environment. And also to remember that we do give a promise. We do not have the healthcare provision facilities. We do not own the hospitals, we do not own the clinics or the infrastructure. But we do give our members the promise that on our 8,000 facilities, they'll be able to get the services. So even in cases of pandemics where an entire, let's say, healthcare infrastructure can be decimated, for example, if you recall like the days of Ebola, then it becomes a challenge. But right now, working together with the Ministry of Health and the government to ensure that all Kenyans have. And as we get to universal health coverage, therefore, all this will be able to be covered without struggling. Because even right now, and I like the tweet about transparency, it would be interesting to learn that for every shilling that we get from voluntary contributors, we pay out 2 shillings. So in order to have a sustainable model, we must be able to have pooled the resources so that we can be able to cover that and even more.
All right, Dr. Gakombe, why is the cost of healthcare so expensive under the private wing? I mean, we know that a number of Kenyans cannot access ordinary healthcare, but also when it comes to private healthcare, you find that a doctor serving under a private healthcare will charge so much more compared to if he's also working in a public hospital.
The fundamental reason why healthcare in the private sector seems more expensive than in the public sector is because in the public sector, the patient is not paying the full price. There is a very, very significant part that is subsidized. For example, if a patient goes to Kenyatta, the infrastructure was built by a taxpayer or by a donor. Doctors' salaries are funded by the exchequer. So the portion the patient is paying is only a fraction of the cost. When you come to a private facility, you have to pay for everything, for the infrastructure, for the cost of money, for the cost of labor. The entire cost has to be met by the service user. And one of the most important comparisons we need to do as a country is what is the real cost of, for example, a cesarean section provided by a county or referral facility versus the real cost in a private facility, because only then can you be in a position to say that the private sector actually costs more. Then as Dr. Mwangangi has put it, the inputs that go into healthcare delivery, one of the major ones is medicines. In the case of COVID, the second major component is actually personal protection equipment. Then there is a cost of labor. We are an extremely labor-intensive industry. Fortunately, we are also primarily a female employer. 70% of our employees are female. So if we grow the health sector or the provision, then we are creating more jobs for women. So if you look, for example, at ICU, the ratio of patients to staff is actually 2 nurses for 1 patient per 24 hours. So that patient has to pay the full cost of that nurse who is a critical care nurse employed 24 hours to look after him or her. So it's basically the cost of inputs. Many hospitals are actually not profit making. Even the ones that are private for profit, don't make much in the way of profit. So that's the fundamentals. One has to pay for the full cost of the service they're getting.
Right. Okay, Professor Anyang' Nyong'o, bring you in here. And of course, good leadership and good governance are also key in ensuring that we achieve universal health coverage. But we do tend to see issues of corruption in the health sector and inefficiencies as well. What is it that governments, national governments and also county governments need to do to address these issues and to ensure that there is political goodwill?
You know, corruption is it's a government-wide issue. In fact, it's a Seattle-wide issue. In order to deal with corruption, there are a lot of things that you need to take into account. Its origin, how it continues to support itself within the system and so on. I'm much more concerned about developing a system of government, a structure of government, rules and regulations, values and commitments that will make delivery of services to the people, whether health or otherwise, at a cost that is reasonable and without necessarily marking up anything because of personal gain. This requires a very strong sense of value commitment in government and a whole array of rules and regulations that are respected because they help the government to serve the people.
And do you believe we
it
have
is not
that?
Something that you can.
Do we have that here in
we
Kenya?
Do have that. We do have that in our constitution, definitely.
In our constitution, that's on paper.
Can I just make my point, please?
Go ahead.
It's not going to help if you interrupt me.
Go ahead. I beg your pardon.
Yes, please. The Constitution definitely cannot be written anything else but paper, okay? And so it is written on paper, but we need to implement it and apply it. And that requires that leaders and those in charge of government must be committed to certain values, which is not something that comes par hasard or by accident, but comes by day-to-day commitment and performance in government. When we were in the NAC government, for example, we introduced performance contracting. And we also in the Constitution, eventually it was introduced a chapter on leadership and values in the civil service. Now, when people break these and then there is no recourse to some kind of punishment or reprimand, then of course people think that these things are just written on paper. So what government needs to do really is to make sure that when rules and regulations are broken, there's some serious recourse in terms of people paying for what they have done. I mean, that's what has been lacking in Kenya, that such processes take too long, sometimes we don't mean anything and so on. And we must confront it and be honest about it and deal with it. It's not just in the health sector, but elsewhere as well. I mean, for example, the recent problem in Kempsa about COVID billionaires. I mean, really, that thing should be dealt with and not just be dealt with bureaucratically so that it doesn't become some people don't pay back for what they've gotten. It should come out in reality that look, something went wrong, people have been held responsible, and these are the consequences. And what you must understand is that historically, some of these things take time because when we started, for example, in the 90s, in the second liberation, there was plenty of commitment for changing Kenya. I mean, the first NAP government, when we got into power in 2003, ordinary people were arresting policemen for corruption. And in fact, the first 5-6 months of NAP government, things moved very well. But eventually, things started going down. Now, we must discover why these things went down. But coming back to healthcare, let me leave, because that's, as I told you earlier, that's a very big subject that requires a whole session on its own, not just here. Let me come back to health. I think Dr. Nginji said something very important, that when you're talking about universal health care, you are not just talking about health care delivery on its own. You are talking about the institutional arrangements in society that make a society healthy. One of the things that we must understand that government services can be delivered efficiently and much less cost effectively by proper use of technology and informatics. We saw it during the COVID-19 crisis here when it started. Just by establishing a call center, you cut out a lot of problems that people had. Somebody is in a village and they realize somebody is sweating, they call the call center, immediately you send a community a community health worker in the village, they go there. And the problem has nothing to do with COVID-19. It's a question of getting the right information on what to do. That is an example where informatics, information systems and technology has helped to improve service delivery. Secondly, it is important that we also invest on research and training. Research to give us new knowledge on how to deal with health problems. Research will help in health, will help in transport, will help in everything else. And thirdly, there are certain branches of health that we have ignored to do research into so as to produce knowledge that can help us deliver health less cost effectively. For example, the area of vaccines. We have noticed with COVID-19 that we are very ill prepared to have vaccination. And we are now realizing that we should develop the capacity to have our own vaccines. It is high time we invested in biotechnology and genetic engineering, because that is the science which leads to development of vaccines. Cuba did it and has done it very successfully. That is why in Cuba, before a child is born, before a baby is born, they get about 7 vaccines before they come into this world. They are armed to the teeth to fight against all kinds of viruses and diseases just by being vaccinated in time. Now, if we begin doing these kinds of things, we'll find that we are very well prepared to have universal health care, not just terms of UHC as we know it, as we're discussing it today, but in terms of Article 43 of our Constitution, universal have access to quality and affordable health care based on knowledge, scientific research, and technology that brings efficiency gains in healthcare delivery. And if we are talking about money on how to do this, in other society, they get this money through what they call sin tax. I don't like the word sin because it's kind of value-laden, it's kind of religious. Let's call it paying taxes on luxuries and luxury goods and so on. Things that you can do without, but then you pay taxes on it if you use them. You see what I mean? In this way, we can really collect that money that Dr. Gidinji was talking about, that we are getting from donors, and we can raise them ourselves. If you have paid your electricity bill, you will be surprised how many taxes you pay. 30% of the money that you pay to Kenya Power and Lighting Company goes to taxes. You have no say whatsoever how those taxes were calculated and why you have to pay them, and yet you pay them. You don't make any noise. But when you are told you have to pay something on luxury goods to support universal health care, you begin complaining. I think Kenyans, let's be a little bit wise. There are certain taxes that we pay. We are not consulted, but we pay them. We don't know why we pay them. We don't know how they are used. And I think one tax that we should pay is luxury taxes to support universal health care.
Okay, thanks so much for that, Professor. Let me just go to our viewers at this point, because people have been sending in comments and questions. We have a question here from Wangeshi. How does UHC work for retirees, considering their needs, medical expenses and access to affordable healthcare? I'll direct that to you, Dr. Kamunyo.
Thank you. Great question. UHC, first of all, is not a scheme. It is not something that, it's not an event that we are starting now. It has been a journey to ensure that all Kenyans have access to the care they need without financial hardship. And note is that all Kenyans. So that includes also the retirees. And NHIF, which is the vehicle through which we are scaling up to get to UHC, would be able to continue the contributions of 500 shillings per month or 17 shillings per day, and be able to access the whole suite of benefits. And should they be retirees and are identified as indigents, as in they cannot be able to afford the basic necessities of life including healthcare, then they would be identified and supported through the government initiatives that do exist. And we do have several, including the Inua Jamii, which is for the elderly above 70. So there are different mechanisms to ensure that all Kenyans are able to access the services they need.
All right, thanks for that. Another question here, and actually, Dr. Mwangangi, a number of people have posted about this question, asking about UHC staff under contract. Will the ministry absorb them into permanent and pensionable jobs? I couldn't ignore that question because there have been a number of people asking that, Dr. Mwangangi.
No, that's a very relevant question, and I'm actually tweeting to some of these UHC interns right now.
Right.
The primary basis of their contracts were temporary contracts. We do have a set of employees in the ministry who are employed under permanent and pensionable contracts. And the request by the interns is to have a conversion of their contract from temporary basis to permanent basis. And for this to take place, a lot of processes have to go into play. One, we have to, of course, undergo through a budget review process, because moving from temporary to PNP terms includes certain budget needs that would be required. I think the second thing is that government has released policies when it comes to containment of the wage bill. And so there are discussions being held, and a team that is actually looking at this together with the Public Service Commission to see how feasible it is to actually do that, or even look at different other scenarios, which some of them may include also extension of those contracts. So this is a matter that is under review right now.
All right, thank you for that. Dr. Gakombe, in your view, what does progress look like in the next 5 years when it comes to universal health coverage here in Kenya?
Two perspectives. The first one is that more people must get into employment, because as you realize, whenever somebody gets into employment, they become a mandated contributor. So one way in which to get more people to be mandated is to grow employment, which then means that the private sector must grow, because indeed all the money that goes to fund healthcare actually doesn't come from the government. It comes from private sector that pays taxes that governments use to fund all services. So we must grow the national cake by growing the economy so that more people can afford. And as you can see from the contributions we are getting, unless people have food on the table, then the question of a mandate to pay for premiums is not a priority. So we must create more jobs, grow the economy, and then make sure that those who can afford are actually contributing towards healthcare. Secondly, we must use the money efficiently. A lot of money goes to waste because the health sector is fairly analog. We are behind other sectors. We must digitize, we must use artificial intelligence, we must use machine learning to make sure that all the money that is available for healthcare actually benefits the person who made the contribution in the first place. But it's a walk we must walk, and more of us must pay by mandate so that there is more money to give healthcare to those who unfortunately fall sick.
All right, thank you. And Dr. Gethinji, as we close, now the Kenyan government had committed to achieving universal health coverage by 2022, and that is just next year. Where are we? Are we set to achieve it by next year, in your view? Or is that rather ambitious?
Smriti, I think it depends on what your target is, because if your target, you see, the way we define universal health coverage is to say everybody in a community, like, you know, Kenya's entire population needs to have universal health coverage. That's important. But at the same time, we know that what is actually, if there was ever a word like importanter, is that the vulnerable must, 100% of the vulnerable who cannot afford to pay what we call impoverishing health costs, or the costs that are beyond their means, must be our new definition of UHC in this country for us to achieve it by 2022. So that we say anybody in the indigent category must have a national health insurance card paid for through government taxes, And when you have that 100% covered, it means now that you actually have 100% because the other people, the employed have some form of insurance because they have NHIF mandated. The missing middle who are informal but are able to pay can absorb costs because they can actually pay for them, and then all the poor are covered. So for me to answer that question, I would say I need to define the target, and that target needs to be that anyone who can afford must be 100% covered. Then we can say that we've actually made a big target by 2022 as we move towards pooling for those who can afford but are not pooled, and therefore they're experiencing high costs when they need care. So if we define it that way, 2022 is achievable. If we say we want everyone to be in NHIF by next year, I don't think it's going to be possible because even the mandatory process requires a process of working with Kenya Revenue Authority, people, participation, but let's cover the vulnerable as our first step, all the vulnerable.
All right, and I suppose we are on the right track in eventually getting there. Thank you so much. Well, I'm afraid we are out of time now on the Nation Leadership Forum, but it's been a great conversation. Thank you so much to all of you, my panelists, for lending your expertise on this topic. That is Professor Anyang' Nyong'o, the Governor of Kisumu County, CAS Mercy Mwangangi from the Ministry of Health, Dr. Gakombe, the Chairman of the Kenya Healthcare Federation, also Dr. Githinji Gitahi, Amref Health CEO, and with me here in studio, Dr. Peter Kamonyo, the CEO of the NHIF. It's been a pleasure, and thanks to all of you for contributing online. We've got to leave it there. I'm Smriti Vidyarthi. Stay tuned. The news is coming up next in just a moment.
For years, others have told our stories and taken our narratives. That has led to misconceptions, half-truths, and outright lies. That ends now. It starts with the truth, our truth. A collection of our ideas, thoughts, and aspirations. Things that propel us, enable us, and ultimately empower us. Find it all at nation.africa. Uninformed, unbiased, and comprehensive coverage of news and events, with in-depth investigative pieces as well as opinions from the best within and outside the continent. Nation Audio will also provide the best in creative audio experiences. Find fresh, innovative segment to stimulate your mind on Nation Puzzles. Stay up to date with the Nation newsletter. It's simple, affordable, and accessible to you with just one click. From 150 shillings monthly. Subscribe. Story.
Enjoy the best family entertainment on StarTimes Classic or Smart Bouquet.
Oh yes.
Premium channels added to give you a complete family TV experience at no extra cost. Novella E+, Nickelodeon, Fox, World Football, Bet King Premier League, and Nat Geo Wild. Subscribe to Classic Bouquet for only $899 for 30 days or Smart Bouquet for only $999 for 30 days. Are you on Nyota? Jienjoy na channel sita zaidi when you pay for more than 1 month on Nyota Bouquet. Kama ni bei, ni StarTimes.